Good morning, everybody, and welcome to the board meeting of NHS England. We're delighted to have a number of members of public here in the room. So good morning to all of you, and thank you for joining us, and thank you to people who are watching this on the screen. So that everyone knows who everyone is, I'm just going to ask colleagues to go around the table and introduce themselves. I'll start with me and we'll go round that way. So I'm Penny Dash and I'm the chair. Jim
Mackey, Chief Executive.
Elizabeth O'Malley, CFO.
Jeremy Townsend, Non-Exec Chair of the Audit Committee.
Linda Walker, Clinical Transformation Director.
Robert Leckler, Non-Executive Director.
Hello, Sarah Jane Marsh, National Director of Urgent and Emergency Care and Operations.
Hello, Mary Watkins, Non-Executive Director.
Tom Cabassi, Executive Director of Strategy.
Jane Allison, Non-Executive Director.
Mark Cubban, Director of Elective Care, Cancer and Diagnostics.
Morning, Suresh Vishwanathan, Non-Exec.
Amanda Doyle, National Director for Primary Care and Community Services.
John Lester, Director of Corporate Governance.
Hi, Tom Grimes, Deputy Director for Freedom to Speak Up.
Morning, Beth Carter, National Lead for Guardian Support and Policy from the National Guardian's Office.
Glenn Burley, Financial Reset and Accountability Director.
And Mark Bailey, Non-Exec Chair of the Digital Data and Technology Committee.
Claire Fuller, Co-National Medical Director.
Simon Wesley, Non-Exec.
Good morning, David Probert, Deputy Chief Executive.
Good morning, Rob Checkett, Strategic Advisor.
Good morning, Mike Cook, Non-Exec.
Duncan Burton, Chief Nursing Officer for England.
Andrew Morris, Deputy Chair.
Great, thank you all very much. So we have apologies today from Mark Walport and from Meghana Pandit. We do have a declaration of interest register. There is one change from Jeremy Townsend, who's no longer a director of Ocado Retail, and there are also some changes with regards to mine. Apologies for that. I realised that it hadn't been fully submitted correctly, and that will be updated online. I'd now like to move on to the minutes from the last meeting. Does anybody have any comments, queries, questions with regards to the minutes? No? Okay, thank you very much. The next agenda item is to hear from different board committees. We're going to start with the People and Remuneration Committee. And Jane, would you like to give us a high-level summary, recognising that we've got the papers here already?
Very little to add, Chair, to the summary. Two good meetings recently. Continued focus on increasing the non-executive and chair pipeline, recognising the importance of good leadership throughout the service. So there continues to be good work going on that. We were obviously looking at some of the work being done on performance, recognising it's a time of some disruption, obviously, with the changes going ahead, but the team is looking at adapting some of that performance training to be more suitable for the kind of circumstances we're going into, and so no let up on trying to continued focus on management excellence there, and in particular sort of establishing minimum expected standards around all our line managers. The rest, I think, Chair, is in the notes.
Okay. Any questions for Jane? Colleagues? No? Okay, thank you very much. Jeremy, Audit and Risk.
Thanks again, I'll be brief. We had a good discussion about the risk registers. After the meeting, actually, we also had conversations with Penny, getting her input into the risk registers. They're on the agenda for later on in the meeting, so I won't go into more detail on that. I think alongside the risks that we've been covering over the last few years within the NHS England, I think additionally we're now looking to look around the risks of transition, and as we transform to the new organisational structures, we need to keep an eye on that, but we also need to keep an eye from an audit and risk point of view on the risk that may have a negative impact on control and the way we manage the organisation. So that's particularly high on the agenda for the committee, and I think with Elizabeth we'll be working with Deloitte to look at how we try and manage that through the transition process, so that we both manage the risk around the transition, but we manage the impact that the transition might have on risk and control. So that's high on the agenda. We're also talking very closely to the department about how we can work closely together on that to make sure we don't duplicate and move towards the new structures over time.
Right. Any questions? Okay, thank you. Robert?
So we had a quality committee meeting. I think almost the day before the Chair's review on safety and quality rationalisation came out. So I think the backdrop to this is that people will be aware that there has been something for some years now called the National Quality Board, as well as the NHS Quality Committee, and Penny and I have been in discussion about how best to manage things moving forward, and I think the likelihood is that one will integrate into the other. So that's ongoing work. At the same time, there's other pieces of alignment which are crucial. Obviously, the 10-year plan. There's a recognition of risk around the migration, all the migration that's necessary to deliver the 10-year plan, and so the next Quality Committee, which will go ahead, will focus on that. The quality strategy is under development, and again, that will be co-owned at the moment by the National Quality Board and the Quality Committee. And then there's reference to the Integrated Quality Report, which is a sort of high-level dashboard, which again we're seeking to align with the National Performance Assessment Framework. So work going on, but I think the future is beginning to take shape in terms of how this will best be structured. One final comment is that we have three very good people as patient voices on the Quality Committee who contribute very constructively, and we're thinking about how best to get the patient voice onto the National Quality Board, and that's an ongoing discussion.
Thank you. Any questions? No. Okay, Mark?
I suppose I'll take the report as read. There are a couple of themes that come out of it. One, across the app and the review of electronic patient records, which is the price of fragmentation and the need for a consistent approach to really get best practice. There are clearly a lot of lessons to be learned in a way of really accelerating technology into the system and making the most of it. There's an ongoing huge amount of work on cyber risk. This isn't an NHS issue, it's across the entire economy that we are going to have to face into now and going forward. And then a long discussion about what the best operating model is, because clearly we need local delivery where the knowledge is highest. We need consistent standards, and therefore what is both the structure and the approach to really deliver business change.
Okay. Would you like, be good just to add something about how you're working with DHSC colleagues to think through how we have a safe transition of our digital and data systems?
Yeah, so we're meeting the week after next with the DHSC. Clearly we run a large number of critical national systems, as well as providing guidance for the system itself. That I'm working very closely with Vin and Ming, the interim CDIO. I think we're getting to the options, started off a wide range of options. We're narrowing down to a sensible group. I would hope in the next 3 to 4 weeks we'll have a clear view of which way we go.
Okay, thank you. Okay, good. Anything else anyone wants to raise at this stage? Okay, thank you. So, Jim, over to you for your update.
Thanks, Penny. So, a quick canter through. Since, last time we met, we're talking a bit about the 100-day plan that's governing our exec activities, as agreed with DHSE and other colleagues. Pleased to say we've managed to deliver pretty much all of what was set out in that plan. So, stuff in there about the ICB changes, the model ICB, the oversight framework, segmentation, transparency, the UC delivery plan, SR contribution, and also the 10-year plan. So a huge amount of work done by colleagues, but with support of the service. I'll come back to the model ICB because I think that's a really material thing for us. We clearly had the 10-year plan published. It seems to have had a very, very good response in pretty much every quarter, certainly in the service. There's huge enthusiasm with the public, with stakeholders as well. Very, very strong response. We had a Chief Exec session last Thursday aimed at delivery of the plan. So now really very much in a delivery phase, using summer to get all the mechanics in place, all the hard work that's going to be required about shaping IHOs, the tariff reform, the allocation processes to lead into medium-term planning in the autumn, which is still very committed to kick off as quickly as we can, late September, early October. Given the Model ICB work is very successful and we're trying to change how we work with colleagues in the NHS, we're going to build that out. And we've had a lot of volunteers from last week to work with us on the development of IHOs, the new FT pipeline, models for neighbourhood care, etc., etc. So real enthusiasm there, and I think we've shown the benefit and feel the benefit of doing that jointly with colleagues in the service. We'll touch through, as we'll go through the agenda, you can see probably still a bit of a mixed picture on performance overall, but it is worth noting what happened to the elective waiting list with 2 months of reduction against seasonal cycles for the first time in 17 years. And Mark and the team are going really hard at just trying to keep that going. It's always hard in summer months. The autumn is much more productive, so is key for us. I'll come back to that because it's material when we talk about industrial action. And colleagues will have seen we're starting to again build out transparency, more data being published and made available. There's another step a couple of weeks' time is to start sharing more routine performance data with NHS colleagues. So currently that's quite hard to find. You've got to have people who will dig around for it all. So we'll be dropping this into colleagues' inboxes in the next couple of weeks. We are sadly though in an awkward place, a regrettable place around industrial action. And I think first of all, let's accept and appreciate everybody has the right to strike and take industrial action. But this comes at a time when we're all cognizant of where society is with us. The British Social Attitude Survey, what the service is trying to do in terms of step up for the public and improving performance, improving satisfaction and outcomes, and also the need to keep everybody together and avoid divisiveness that industrial action inevitably causes. We are very hopeful still that it can be avoided, but in the circumstance where it can't be, we've really stepped up through Sarah J and our preparation for that, and as part of that we should be clear that given the learning from the last period of industrial action and papers that came here in the autumn and various other reports that we've seen around harm and the impact, that we can't take a tight definition around service provision that was taken the last time. So we'll be taking a much different approach in stepping up our activities with NHS leadership tomorrow, encouraging them to be clearer about safety and that those responsibilities and choices sit with them and their management team. I would completely reinforce that. I would really hope that this is avoidable and that we can, the relevant people can have talks, make progress over the next few weeks and avoid it. So, and then just finally to just draw out, as we go through the report, picking up on the kind of mixed picture, there are some really strong positives. We're really ahead of the game in terms of winter planning relative to previous years. Sarah Jane will guide us through this later on. Financial performance so far is so much better than it could have been, led by Elizabeth and colleagues. Then also we've had a series of events through professional groups, chief execs a few times, CFOs a few weeks ago. Duncan had chief nurses in a room on Tuesday this week as well. We're trying to step up that engagement, enlist support, keep the community with us, which I'm glad to say has been really, really impressive and very, very much appreciated. So I'll stop there, Penny, and happy to take any questions if there are any.
Okay, thank you, Jim. Andrew?
So, Jim, just reflecting on previous years, what was the cost of industrial action for the NHS? Because clearly that's not going to be funded centrally. It'll come from our resource base, won't it?
Yeah. Elizabeth, do you want to answer that one?
Yeah, so happy to. So we've looked back and over the period, because obviously it was more than 1 year, it was about 36 days of industrial action for just the juniors. It was estimated the direct cost alone was £1.5 billion. That's not including the lost productivity, the fact that people will be profiled on annual leave and then etc. So those indirect costs, it's not including that. obviously, when we've looked back as well, I've looked at the variability of the estimates and some of those costs that were coming through by provider, system and region. And for me, I think in the event that we end up with industrial action again, we'd have to take quite a different approach, actually. There's been a lot of learning, and I think there was a lot of cost incurred that we wouldn't anticipate to happen again in the way that it had originally.
Okay. And just reflecting on the kind of safety issues, Jim. Again, the way we set it up last time was it was the kind of national framework that people had to comply with, and I don't know how many kind of incidents were reported as a consequence of the strikes, but I assume that we'll be asking Trust to do that again, where they believe that safety has been compromised.
Absolutely, Andrew. And this is, I mean, Sarah Jane and others chip in as well. This is it's really complicated to be able to identify the harm and impact directly to the industrial action. And that whole Christmas Day service, that was part of agreed process last time, but we need to take a different position this time. I personally met patients and families in my Trust life who'd had late cancer diagnosis, late Parkinson's diagnosis, came to harm later on, that were not caught in that initial assessment and reporting. And the amount of disruption that ripples through, it actually takes months for these things to actually settle. So there is a danger you look at very discrete periods of time with a very discrete range of services, but then miss the broader picture. And that it's impossible to measure the avoided access where there was a hesitancy in the population to come forward because they were worried about what could actually be provided, or not want to put unnecessary strain on the population. That will never quantify that, which is why I think we just need to take a very different approach. We all tolerated levels of harm and risk last time that I really just don't think we should anymore, and it's going to be very, very tricky to navigate, but hopefully we'll avoid it. Hopefully it will be averted, and if not, we'll have to work in partnership with colleagues to address it.
Okay.
So I've got questions from Jane and from Robert. Let's take both questions.
Thanks, Penny. Obviously, large numbers of resident doctors didn't vote to strike, if you look at the numbers. But I think for many of them, whether or not they did, some of the non-financial issues and sort of concerns will be still uppermost in their mind. And perhaps can you just give a kind of update as to where we are with following up on some of those? Because I think a lot of those are very material to people's sort of working lives.
That's a really good point, actually. So there are a range of things that we've all known about for quite a long time that have caused unhappiness with resident doctors, and were part of the package last time around food and the exam costs and these sorts of things. Hand on heart, I don't think we've systematically addressed those issues with the urgency required and as systematically as required, and we need to pick up pace on that because it's a significant contributor to the understandable dissatisfaction. From my discussions with resident doctors, and again colleagues chip in on this, there is also massive dissatisfaction with the system that they have to go through to be appointed, to find out where the rotations are, being sent to places that are inconvenient and difficult for them and their families, etc. And they were understandable systems built in the early 2000s. I really think we should be challenging that and working with them to reconstruct a system that gives more local ownership and belonging and more sensitivity to their needs, but actually also trying to reconnect colleagues to the local community in which they work in. So for me, I would extend the non-pay actions into that as well. And then the financial side's been well covered through the media and other colleagues. I don't want to inflame that further, but everybody knows there's no money. There's no money in the economy. We're not going to get any extra money. So it's a zero-sum game. Whatever goes into that deal has to come from somewhere else, which I think we're all wanting to avoid.
Robert?
Yeah, so Jim's just made the point I was going to make. I think getting the allocation of training posts right and the structure of training so that the juniors or the residents have a sense of belonging, continuity of patient care, being valued and all that stuff is so important. And I think it's underlying a lot of the disgruntlement. And it's not only important because it's important for the existing trainees, but if we don't get it right, then we're breeding a bunch of disgruntled juniors that will become disgruntled consultants and so on and so on. So I think it's difficult to exaggerate how important that is, and I just totally support the work that's going on.
So we'll pick up on metrics in a minute, but it maybe, given we all recognise this is an important area, and because it's not just for resident doctors, it's for all staff, how do we look at well-being and having a positive working environment? I'm very conscious we don't have that in our metrics.
No.
And maybe we should look at how could we capture that on the basis of what gets measured gets done, sort of principle. So I think just one thing on industrial action. So I know, Jim, you have very deliberately cut short your holiday to be here during the strikes, should they go ahead. And I think we all like to say a big thank you for doing that. I know it comes at quite considerable personal cost, so thank you for doing that, and hopefully we can avert it. But should that not happen, then it's good to know that you'll be here, as well as other colleagues, obviously. Okay, so let's move on to performance and delivery. David?
Thanks, Penny. Good morning, everybody. This is our integrated operational performance report, which, as you'll see, is built into 5 key sections, and I'm very conscious that my colleagues around the table are responsible for each of those sections, so I'm sure we'll be delighted to take any detailed questions on each of them. And Elizabeth, of course, will pick up the finance detail afterwards. So just from the outset, maybe if I summarise where I think performance is in each of those sections. Firstly, to pay great credit again to our hardworking NHS staff who are continuing to deliver well against a set of challenging targets this year. We know we're doing well, as Jim has set out in a number of key areas, but particularly with urgent emergency care and elective wait, we know we have further to go to achieve the ambitions that we have set out in the 10-year plan. Just to start with, if we pick up quality and safety, you'll see that this is one of the first times we've tried to focus on as much transparency as possible. There will be more to come as the quality board that Penny's outlined before is set up and the details are flowing through this report. But we absolutely have an ambition to make the NHS the most transparent healthcare organisation in the world, and this is our starting beginning. We are looking to publish league tables relatively soon to rank our providers against these key quality metrics, and we're very, very keen. We've made good progress in giving patients real access to transparency, of course, through the app, and more of that to follow. Just in terms of quality and patient safety, you will see from the report that the summary hospital level mortality indicator, or SHIMI as we know it, is at its lowest level for the last 2 years. You'll also see that from a CQC perspective, we have seen an increase in the amount of good and outstanding results. But again, in the spirit of transparency, we have to be clear that there are less inspections at the moment and they are risk-based at the moment, which will be skewing those numbers. In terms of urgent and emergency care, Sarah Jane is coming on later to talk about the fantastic work underway to plan for winter, which we know will be challenging yet again. But it's really important to set out that we continue to see huge demand on our services. June, it depends on how you feel about the hot weather, but certainly almost half the days we faced a heat challenge, which put health alert, which put a tremendous challenge on our services. Yet despite that, we're continuing to operate at around nearly 76%. So we have a lot of work to do, but you can see also from the ambulance performance that good work is underway, particularly around handover and flow. So our focus is on today, but our focus is on tomorrow, and Sarah Jane, I know, will pick that up when we come on to talk about winter. In terms of elective care, I guess the headline would be that patients are still waiting too long, but we are making good progress, particularly focused around our long waiters, where you'll see us moving towards constitutional standard. We've seen a record number of patients. Just to give you an example, in May alone, we saw 75,000 planned treatments per day in May, the highest number on record, and certainly some way ahead of where we were in pre-pandemic levels. So people are working incredibly hard to get to where we want to be, both in terms of treatment and in terms of diagnostics, and you can see that from the figures set out. We are working hard on the longest waiting patients, particularly the 52-weekers and the longest waiters. And the balance at the moment for our colleagues in provider land is how we deal with what's known as dealing with those longer waits, tail gunning, but also reducing the larger picture of RTT. And you can see that we are on track, and our ambition still remains, of course, to hit the 65% target that's been set. The next section is cancer, where I'm pleased to say we are treating more patients and we are treating them faster. You'll see this relative success in the faster diagnostic standard and the 62-day standard. We have quite rightly set our ambitions further this year and as we move forward, and that will be a challenge, and we are not where we want to be on that ambitious standard. But I think we should pay great credit to the work of those providing cancer care that we are making such significant progress in a number of key areas. Very importantly, mental health continues to be a key objective in improvement in mental health services, particularly around child and young adult access and flow in and around our mental health providers. And you'll see from the statistics provided that, again, more children and young people are accessing mental health services than ever before. The percentage of outpatients being discharged with a 60-day length of stay is lower than previous months, which shows that elements of our flow are starting to improve. But again, there is more work to do. You can also see that in the percentage of outpatients in crisis who are now receiving face-to-face contact within 24 hours, which has also increased, which is, again, a good credit to those colleagues that are involved in mental health provision. But there is more to do, particularly in the provision of community care. So final thoughts just around the performance review, and then an opportunity for colleagues to pick up any key areas. I think it's absolutely clear that we are continuing to remain focused on both the constitutional standards and the plans that we have set out in the 10-year. During the first half of the year, we've made significant progress, as I said, on those long waiters, but the RTT in general remains key. Urgent and emergency care remains in a good position, but more work to do, but encouraging signs, particularly around ambulance handover and the 4-hour target. And cancer and diagnostics are improving, but to meet the ambitions that we set ourselves, we know we need to do more. Everything we do now is focused around those 10-year ambitions. Everything we do is focused around transparency, and I hope you can start to see that in the beginning of this report. So very happy to take questions, Chair.
Thank you, David. So I'm sure we'll have lots of questions. Okay, so I've got Andrew, I've got Jeremy, I've got Robert. Let's take all three of those.
Okay.
And then come
so
back.
Great to see the report and the detail, particularly around mental health. That's the first time we've had that level of data in front of us. Be good also to have a mirror image of what's happening in maternity services, given the kind of national focus on that, and on community, which I know, David, you've just touched on. My question is around what are we doing to help the 10 or 15 trusts that are really struggling with 4 hours and 12 hours, and what support are we giving those organisations? Because if we can lift those into a better space, the overall performance will hopefully kind of jump up.
Okay, I wonder, Andrew, whether that is better if we pick that up with Sarah Jane when we come
Sure.
to UEC and winter planning.
Yeah.
Is that right? Because I think that's about what are we going to do rather than the data per se.
You know, the board's complete unless the first question comes to me about UEC from Andrew. That's the pattern.
Okay, maybe we'll try and change that. Okay, Jeremy.
So we've got a finance and productivity section, but it's actually really just about the situation within each of the deficit. So I guess productivity difficult to measure, but a massive opportunity. We know it's been a challenge, particularly since COVID. And I guess a question for Elizabeth as to, is there a way of reporting it nationally, and how can we get a better grip on what's being delivered and what the opportunities are? Because it feels like something that we should be looking at this level.
Yeah.
Robert, I'm going to take all the questions.
Yeah, so thanks. It's great data and it's great to see. A couple of questions on effectiveness and experience of care. One very specific, and it may be me being stupid, but slide 8 on the standardised mortality. The heading says percentage of acute providers with a summary hospital mortality lower than national baseline, and at the bottom it says the percentage indicator higher than the baseline. So I just wondered which it was. I assume it's the latter.
Yeah.
The more general question is, firstly, there's nothing, as far as I can see, on primary care. And secondly, in terms of patient experience, there's patient experience data on mental health, but not on general patient experience. I'd be interested to know the thinking behind that.
Okay, so let me just add a bit which follows on really from what Robert and Jeremy both said. So I think great that we've got this. Great we're starting with quality, really important, really good to see that. But it is quite noticeable the gaps in here. And yeah, so lack of any primary care data was the first one that jumped out for me. Lack of any data on diabetes or heart disease, despite those being our sort of most important drivers of ill health. But we could actually come up with quite a long list of things, and we were talking as non-execs last night. We all noticed the productivity, and we'd like to see a lot more on that. So I guess there's a bit about, otherwise we'll end up with 100 pages. So how do we use things like the FDP, and you've mentioned this before, Jim, how do we use sort of more modern day data tools to allow us to have some high-level data? And I think we do need to do more work to agree what are the priority metrics. I'm not quite sure these are the high priority metrics, but also how do we have an interactive tool that would allow us to dive down and see a lot more, and then be able to have a more informed conversation about a much broader range of things, which could also then pick up on variation across the country, because absolute numbers are one thing, but the variation is the bit we really need to be looking at.
Yeah. So. Well, just if I may respond, Penny, to that. So firstly, thank you for the comments. We'll take those away, particularly the focus on those areas that you've mentioned and how best we highlight them. I suppose just to assure the board, when we do our regional performance reviews, which we've just concluded with every region, we are absolutely diving into the detail of those types of services you're describing, particularly maternity, and actually community spent a lot of time talking about recently. So we need to reflect that in this report. There are much easier ways to do that now than perhaps we had before. So we'll take it away and think about how best we produce something that is summary, allows you to dive in, but isn't 150 pages where you don't see the wood for the trees. It's just what we're trying to do. So we'll absolutely take those away.
And then specific questions?
Yes, so in terms of primary care, I don't know whether, Claire, you wanted to comment, just that there are lots of positive things around performance.
Well, there is one slide in the pack, isn't there, that talks about patient experience of access to primary care, and you can see the sustained improvement. And then this week we've had the GP patient survey that has also been published, which also shows, so the data we use in the pack comes from the Health Insight survey, which is done by ONS, and we've seen that gradually improve over the last years. First, to acknowledge there's a lot more to do, but the trend is going up, and again supported by GP patient survey that again showed this year, again marginal improvement, but it is starting to improve. So I think we should include that as part of actually looking at how we monitor access, particularly on the day access. We do regulate, we've got the data as part of our oversight framework around hypertension, and we've got it around diabetes, the 8-step care processes. And we do just need to keep including it. Including it in this pack, we've got the data. We need to include it. We've been doing the regional meetings. We have been talking about community services. We have been talking about mental health services. Have a deep dive into dental, and particularly around elective, start and reflect how GP referral patterns, use of advice and guidance. So although the headlines reflect activity within trust, a lot of that is led up to by a whole system performance, and I think we sometimes forget that.
Yeah, but I think there's a bit about bringing it here.
Yeah,
so
absolutely.
Good to hear that you're looking at it, but the point of the board is that we can look at it.
Can I just come back specifically on the patient satisfaction in primary care? Because how many times I've heard quoted the ONS data saying 21%, only 21% of the public are satisfied with the NHS, and that just doesn't square with the GP data, which, as I recall, is 67 or 70%. So I think we need somehow to address that in the way that we portray what's going on, because it just otherwise is a self-reinforcing doom loop.
Elizabeth, do you want to pick up on productivity metrics now?
Yeah, of course. So the heading in the report should have said finance for this month, Jeremy, you're quite right. So as a quarter one, which clearly we moved into, We are starting to report quite very transparently our productivity data across the 5 domains, particularly areas that you'll be familiar with because we've reported them previously, but we'll do this in a more granular way on workforce, reducing waste, shifting care transformation, and then clinical ops. The clinical ops work I'm doing with colleagues like Sarah Jane and Mark, so outpatients is a big feature this year. But given that we are ramping up the way that we're reporting, there will be some fairly basic information at the start of the year, and that will improve as the year progresses. I also have a productivity group now established within NHS England, and we will bring members of this service in to have the discussions with us. And for example, a lot of effort and energy coming from our mental health sector saying, how can we be involved? So we recently met with a group of CFOs to start talking through what would be meaningful for them, recognising the data sets are not quite what we would hope. And then taking the challenge that we've had previously from the board, we do have a high measure of productivity to report into government. That's not particularly meaningful for the sector, so we are breaking that down into its component parts, so there's something that everyone can use. And there's a huge amount of interest, so we are just about end of July, we are going to be launching a dashboard that takes productivity and cost data down to HRG level. And I would say there were 50 providers that were involved in some of these recent discussions, and everybody's saying, when can we get our hands on it? We will be publishing that data. It's not a league table. It's going to be something that sparks people's curiosity, actually.
Great, good to hear. Jane, did you want to come in?
Yeah, thanks. It's picking up a little bit on some of the aspects around reporting performance in primary care. It's really just putting a marker down for the future around prevention, because if you look at the 2 measures that will be reported on a biannual basis, they're prevention of further harm. They're not really prevention of the condition. And although we know that a lot of the big picture preventative measures you can take in health, change over a very slow period, and kind of quite hard to land with the public for that reason. I just wonder whether some thought could be given to proxies for success in that area that you could measure through, particularly through primary and community care. So it's not one for now, but I think something that can be integrated into these sort of statistics, which is about things genuinely prevented rather than, for example, hypertension being treated. It's more kind of people being proactively prevented from getting to that point. So I think it's worth thinking about the design of that now as we move towards, the left shift in the 10-year plan.
Yeah. Well, let's take Mary's question and then come back, David and Clem, to come in.
I just wanted to ask whether we've got a proper structure to report on childhood vaccinations. I mean, we got this problem with measles, and I think we could focus on pre-pandemic planning with older people rather than looking at that across the board. So I wonder how we'll report that in future.
Thank you, Chair. So, both really important points, and particularly thinking about cardiovascular disease in a different way and how we prepare that work. On vaccinations, we do have a lot of that data available, so how best we, again, in summary form, bring that in, particularly with what's been happening in Liverpool. But Claire is...
Yes, so it's the primary and secondary prevention, isn't it? So I think we've got very good ways of measuring secondary prevention, particularly around cardiovascular disease and diabetes. We've just launched the Neighbourhood Health Implementation Programme, and as part of that we've got a design day in August, which will be looking at how we judge whether the programme has been a success. And the important bit about the way the programme was launched, it was out with letters out to the ICB chief execs as well as the local authority chief execs. And one of that session will be looking at more population outcomes-based measures as well as the NHS outcome framework, and actually how we bring those together to give a set of metrics that will address, as you say, that broader prevention than wider determinants, but that also impact upon NHS performance. And I think when we've done that work, we then need to bring that through back into the integrated pack as we go forward.
Okay, so I'm going to suggest, because obviously lots of interest in this, which is great, we're going to do a little bit of rejigging of some of the board committees from September anyway, and Robert's already mentioned changes to Quality Committee and the National Quality Board. So I think some of the first piece of work through the National Quality Board and Quality Committee of this board needs to be agreeing what do we think is a comprehensive set of metrics. It will absolutely be a long list. I suspect we'll be up into the order of 200 on quality, which would include things like primary prevention, childhood vaccination, a whole host of things. So what is it that we will want that National Quality Board to look at, however frequently it meets, every couple of months, let's say, in terms of a detailed set of quality metrics that look at all aspects of quality? That is a key piece of work. We've got a performance committee. We need to say what are the key metrics of performance overall, which include all aspects of performance that go through the performance committee. How do we look at that in detail there, bring a summary here, but also have the ability to dive down? And then crucially is to make sure that our sort of core set of metrics that go into the oversight framework, we all get sent every week and go into meetings with Secretary of State and other ministers are consistent, and that we're all seeing those and that we all agree that they're the most meaningful set of metrics that we want to be looking at. So key bit of work that comes out of this that we should aim to be in a more consistent place, I think, by the end of the year at the latest on that. Is that okay for everyone?
Yeah.
Okay. Oh, Mark, and we need, actually, Mark, looking at you, I would also think I was going to say that as part of that will be the metrics by which we are going to monitor implementation of the 10-year plan, and as a crucial bit of that, our favourite topic of outpatient redesign.
Yes.
Presumably that's what you're going to say, Mark.
It was in my mind.
Yeah.
Yeah, definitely. Penny, can I just mention one thing related to the quality of care aspects, particularly around cancer patients, if I just would add to it? Yeah. So today we published the results from the National Cancer Patient Survey, and I just wanted to share it with the board if I could. So it's now published at 9:30 this morning, and we will make sure everyone has a copy of the results. But it's really positive. So we've had the best results for the overall care provided for cancer patients for 4 years. We've been looking back for how some of the questions going further back, how comparable they are, because the data set was changed 4 years ago. But we have an overall rating of just under 9%. Well, 9 out of 10, rather. So it's 8.94 out of 10, which is the most positive rating that we've had. And just an indication last year was 8.89 out of 10. So it's a really significant step forward. And I know we hear a lot about things that we need to do better. But I think there's big opportunities for us to learn about things that are going well with the experience for cancer patients and think about that across the broader groups of patients around outpatients, urgent care, and for inpatients as well. So really good feedback about things that we're getting right in terms of teamwork across and the coordination of care for patients, and also looking at how patients feel involved in the care and the contact they're having with our clinicians. So I just thought it would be good to mention it today, given the fact it's only just been published this morning.
Great. Thank you, Mark. Elizabeth, did you want to bring up other aspects of finance?
Yeah, so hopefully people have had a chance to read the report. The paper sets out a brief update, obviously, on the spending review, just to conclude that for the record, and also an update on the month 2 financial position. Would you like the key headlines? Yes. Yeah, given the time in yet. So in terms of the spending review, obviously in June concluded phase 2 of the 25 spending review. We now have revenue budgets through to 28-29 and capital for a further year, so 3-year and 4-year revenue and capital budgets. This will really help when we move into medium-term planning. We will also plan to give some indicative budgets for further years just for planning purposes, and we're talking to both the Chief Exec and CFO community about that more recently and engaging with clinicians. If I was to look at moving perhaps straight to month 2 position, so planning for 25-26 concluded early this year. That was after application of £2.2 billion deficit support, but we now have plans with 42 systems have submitted break-even plans. In aggregate, you'll see in the report, including the NHS England position, the overspend year-to-date at month 2 is a £51 million overspend, so that's 0.2% of our year-to-date allocation, which is low. But within that, there is a year-to-date overspend in our systems of £110 million. That's a year-to-date overspend. This is concentrated predominantly in 4 systems. You'll see in the annex which are those systems. So North East London, North Central, BSW and Birmingham and Solihull, but that data is there. Encouragingly, half of our systems and 75% of our providers are on plan at month 2, and at the same point this year, comparatively, the £110 million year-to-date overspend was actually 240 million, so we're in a better position overall. Efficiency is a key driver, obviously. So we've got £159 million shortfall at month 2 in our SIP plan, but that's been offset. Provider pay remains flat, but we are actually seeing a decrease in headcount compared to month 12 of last year at 1.4%. And then if I could, hot off the press, I guess, Q1 numbers. So very much month 2 was for the record. So at Q1, comparably, the £110 million year-to-date deficit has reduced and is now 78 million, with 4 systems making up over half of that. The systems are overall showing this improvement. And we're also seeing a slowing of the run rate of overspend. I just want to say again, similar to David, actually, a tremendous sense of energy and focus on money. We are not tackling money without thinking about quality and access. That's not what the CFO community are doing in the discussions we've had. Definitely, having been a regional director, moving back into this role, it's very much alive in my mind. But I just want to say testament actually to the community out there and the way that people are focused and getting involved. So amazing work. There are some key risks in the paper. Andrew's picked up one of them, which is the potential risk of industrial action. And whilst month 3, quarter 1 is a hugely positive position, it's high risk and we've got some back-ended plans. So we are day by day, week by week engaging with the service. But the response has been amazing. So in conclusion, I think the financial outlook provides real terms growth and the systems start from a balanced financial position, which is good. We're on track at Q3, but there's still a lot of risk to mitigate. And this is going to make delivery challenging for the remainder of the year.
Okay, thank you. Mark?
Elizabeth, clearly there's been an enormous improvement in performance from quite a large proportion of the system. Are there, and like 1 quarter and it's super early in the year to do this, but are there lessons that we can already start drawing out about what people are doing differently now?
Yeah, Jim might want to come in as well. The response I've had, particularly from the CFO community, and later today we'll be talking about our oversight framework. The thing that people have really welcomed is the transparency, actually, and not just the transparency shared back with NHS England, but across the systems, and there is definitely learning that's going on. So there have been efficiency programmes, and our productivity packs actually have driven a different quality of conversation, both around the board table, but also across the CFO community. So I think there's lessons there. I also think we've pointed to quite a lot of examples where I know people don't like the term waste, but actually we're seeing variation in spend that you can't really justify. And people have gone back and tackled that. And where they haven't been able to tackle it, I think it's remarkable in such a short period of time that people have come forward and genuinely said, we don't know when we need some help. And there has been that help on hand, either within NHS England or there's someone somewhere in the NHS that knows how to do it, because that's how we've got variation. So we've been putting people together to do that. So we've called it a little bit of a finance amnesty through the summer. It's kind of like it doesn't really matter if you don't know. I've been 6 years of finance, so I'm building my muscle memory. That's the way I've described it. So it doesn't really matter that you don't know, but what does matter is that you know by the time we get into the autumn, because this gets tougher as the year progresses, and there's an awful lot of other things to do, including medium-term planning, of which the whole service, the whole population is looking at us.
And I would just add to that, completely reinforce what's just been said, actually. So really strong leadership response, people really facing into the issues and engaging on it. I think pointing people to the variation, sharing data, making it more transparent, encouraging boards to challenge, where they're an outlier, get a hold of that again. I think it's all been fantastic. And then a few of us had an exchange last night. Fortunately, yesterday I had 3 interactions with colleagues, 1 FD, 2 chief execs, who all independently said, this is tough, but really good, actually, really welcome it. Very, very keen. One of them was very keen to use the platform of this year to become a new FT and knew what they needed to do. They had a medium-term plan development in terms of where, how they could see a path to that. Conversation with Chair the other day, who was very, very keen to point out that there was segment 3 now because they have a deficit, but when they get rid of that deficit this year, they think they could be segment 1. And then finally, what Glenn and colleagues have done on the Oversight framework, I think it's really fantastic, actually. So we grappled with this at the beginning of the year. It's not right, it's not perfect, but in terms of the behavioural response and the belief that actually now I know if I deal with these things, I can progress, I think it's really powerful. And we will tweak that and we'll change how it incentivises the certain things, and it'll become dynamic over time. But I think that is really good to see in real life.
Okay, I've got Jeremy, Robert, and then Glenn.
Just a comment and a request, really. Just stating the obvious that this is very tight. It's good progress. It's great to see the level of engagement. But if there is a 1.5 billion challenge created by industrial action, and hopefully we can overcome it, that creates a major challenge. And it's really a request, really, that if we end up in that situation, we have to make some really difficult choices to bring those back here so we can discuss the trade-offs there, because I know that's going to be very difficult given the challenge to just balance the books at the moment. So really request on behalf of the board that we have a look at those and see what those difficult choices look like.
Okay, Robert?
Yeah, no, great work, Elizabeth. Can I just ask you, probe a little bit on capital? So I'm sure this capital budget could be spent several times over in the secondary care sector, but I'm also interested in the neighbourhood health model, which, as Claire was saying earlier, is to be defined. But I would be very surprised if one of the consequences of that isn't that the premises needs to be revised to consolidate and accommodate multi-professional teams, etc., etc. Is there any thought as to how that capital cost might be met?
So in the spending review for coming years, we have put some early estimates in for neighbourhood health. As you described, though, Robert, there's a variation of views about how big and how costly those buildings and premises could potentially be. The strong sense is that a lot of those premises actually exist. So this is modifications. So we think we can do this in quite a cost-effective way. We've got some fantastic CDCs, for example, that are not being fully utilised, and they would be a fabulous vehicle to go forward. So I think it's hard to predict and estimate what the costs are going to be until we really get into the model. But equally, we have got a line of sight that some capital will be required. But as you say, it's about trade-offs, because actually capital across the spending review period is broadly flat, despite the work that came back from Darcy.
I think we will need a more detailed review of capital at some stage coming. Glenn and then Duncan.
I was just going to emphasise the point about that accountability of individual trusts and boards. We're looking here at the ICS level data, but through the Oversight framework, looking down at the individual organisations, both from a finance but also a productivity perspective. As Jim said, that's really helped to focus people, and we will see improvement as a consequence.
I was just going to say, I think one of the concerns that's out there at the moment, given the tightness of the finances, we should just recognise that there are newly qualified nurses and midwives who are finding it more difficult at the moment to get jobs. We are working very hard on this. I held a summit on Monday with our regional teams to go through this. We've been working and looking at support outside of the NHS, because there are jobs in social care, the independent sector, and of course some of this is because we've got better retention rates than we were expecting as well, which is clearly a positive thing, but we are doing as much as we can do to make sure that we support people into jobs. But that is clearly one of the perceptions around the financial situation at the moment. It's driving this.
Okay, and at some stage we need to work out how many we need, which is a different question, which presumably will be through the workforce plan. Yeah. No.
I just wanted to come back on what Duncan has said. I mean, I really know how hard everybody's working, but we also need to get the message out to newly graduating healthcare professionals that you can't automatically expect to get a job in the area that you've trained, because there are vacancies in different parts of the country.
And we've been working with the HEIs on that.
Okay, thank you. Andrew?
So, Elizabeth, just looking forward, because organisations are faced with having to take 2% out potentially every year during, the plan period. Are we sharing the kind of top 10 things with boards so that they can get a fix and plan ahead? Because I think the trick here is to, get your CIP for the following year sorted out during the summer months and really buttoned down. We don't want to miss out on that kind of opportunity.
Yeah, absolutely. People really appreciated, the feedback we heard was they really appreciated the productivity packs that we produced for this year's plan. We plan to reissue those. I think we're hoping it's going to be the end of September, beginning of October. So that a whole lot of extra data, the data quality will have improved because we'll be another year on and we will have used it. And then there were some particular themes people wanted us to look at too, as well as I'm really keen, as is I think Penny, that we look at costs per 100,000 population, including some of our staffing. It's really, when you look at the data, it just leads at you to ask so many questions. And many of them are coming back unanswered. We're not judging people about that, but we're asking boards to really face into it. So I don't want to pick particular staff groups, but when you look at the values of activity versus the costs and how they've grown over recent times in certain specialties and professions, it doesn't really stack up. Now, there might be something, because equally quite a lot of operational and finance people are coming back and saying we're doing things that we're not counting. So that's the other challenge I think with Jeremy we've been talking about, making sure we understand not just the productivity measures we're traditionally counting, but what are the other things that we don't give the service the benefit of because they're different as new models are coming on stream.
Yeah, I don't want to end on a negative on all this, but we've had 2 very strong published months and a hot off the press good month, really strong start, all the things we just discussed, which is absolutely fantastic. I'm not a big counterfactual man, but the counterfactual was pretty horrible, when we started this year. We should all know and understand, though, we'll wobble. There'll be points at which the numbers aren't great through the year. It's how we respond to that. So if we can all just get ourselves mentally ready for that. It'll be a miracle if we get through the year, IA aside, for every month to just be consistently better than the last. So we'll work on that, make sure we respond appropriately. We'll have proper board discussion and, importantly, continue discussion with the service about it.
Yeah, great. So I think picking up on that, the more that we can try and I know some of this happens in the more detailed conversations, but there is a bit about trying to understand what are the drivers of the financial position in each system. So on the Annex 1, a couple of thoughts. One is it'd be good to show the absolute figures that are here as a percentage of their total budget, because they are quite different sizes, and so we should probably be looking at it as a percentage as well as the absolute figures. The second is to try and separate out a bit ICB performance versus provider performance. And so it would link a bit to the previous conversation. If you've got an ICB where, for example, we've got particularly poor rates of quality of care for a number of conditions, or we've got high rates of emergency admission to hospital, it would be good to see that as a driver of financial position as much as provider performance, so we can sort of get a bit beneath the skin and understand what it is that's happening in different areas. So I think, again, there's a balance here between not swamping us with data, but having some sense of what's going on in each of these areas would be helpful.
Happy to do that.
Presumably that comes through some of the oversight framework work as well. Okay, good. Very good conversation. Thank you, everybody, for that. So, picking up on where you were, Jim, let's move on to risk and how we apprise ourselves of that. So we've got John here, along with David and Jeremy.
Thank you.
very much, Penny. And thanks to you and Jeremy for your support in developing this new two risk registers, which you'll see. One is strategic in its focus, one is operational, and both will work alongside the risk management framework, which we're also asking the board to approve today, which is included within the pack. John is going to take us through just a little bit of detail on both registers, just so you can get a feel of the way we've tried to operate. But just a couple of quick observations. Firstly, we're delighted that this is the first time we're bringing these registers to public board. We think, again, in that spirit of transparency, it's incredibly important that we do. Also, just wearing my other hat in terms of managing a hospital, a risk register works when it feels real and when you can tangibly look at the detail and think, actually, that's what keeps me awake at night, and this is what I'm talking about a lot. And I would argue when you look through these risks, both strategic and operational, they very much mirror what we're going to be talking about an awful lot this morning. And finally, we're delighted that risk registers can sometimes be seen as a bit of a bureaucratic dry thing, and we're really pleased this is towards the front of the agenda, nestled behind the strategic conversation, because we're very much of the opinion that risk should drive strategy and risk should be inherent in all the strategic conversations we have. So it is within that light both the strategic and operational risk registers are put together. But a big thank you to John and his team who've done an enormous amount of work, and perhaps if I hand over to John just to give a bit of summary on both.
Thank you and good morning. Yes, I'd like to pull out 3 points from the strategic register. There's a new risk at the top around developing a coherent set of strategies and delivery plans. So that's in relation to the 10-year plan, but also our objectives more broadly. For example, our duties around reducing healthcare inequalities. And the mitigations to that are what you would expect, our ongoing work around 10-year health plan delivery. Also a new strategy committee we're standing up in the autumn that will give oversight and coordination to that development work. The second point is around the second risk, which is changed from the last version and is around the scale of change required to deliver the 10-year health plan and create the conditions for success. And that's, again, relating to work the board will be familiar with around the Oversight framework, model ICB and region blueprints and the wider system architecture. And the third point is just to put out the theme that some of our top risks continue to all be around data, digital and technology. So you'll see towards the end of the register that we've got cyber attacks against the NHS, a data breach within NHS England, and also being able to maximise the opportunities from new technology and innovations, all being very highly scored risks. So that remains critical for us. On the operational register, and this is our more sort of short-term risks, more likely to be mitigated through systems and processes, and also our mechanism for escalating risks up from teams around the organisation. I won't go into detail, but there are 3 that have gone up since last time that I just wanted to call out. One is industrial action, for obvious reasons. One is around the delivery of IT systems to support the performance list, which is our register of primary care practitioners and revalidation of them, and also delivery of the in-year financial position, as we've just heard. And I'll touch very briefly on the risk management framework. This defines our approach to risk management in the organisation, makes sure we do it consistently and in line with good practice. We already have one. What we've got here is shorter, simpler and easier to follow. It formalises some of the risk governance arrangements that we've already been embedding over the last year, and also enhances how we develop and manage cross-directorate risks. So that's here for approval, acknowledging that we'll have to keep tweaking it as the committee structure evolves.
Jeremy?
So, great piece of work. Well done, John. This has moved on a lot. Anybody who's sat on the audit committee over the last 3 or 4 years has moved on leaps and bounds, so thanks very much. But I guess I'm going to channel Jim's counterfactual here. This is where you start, not where you finish, because it's all right articulating the risk, but if you look at the piece of paper, there's a lot of risk, and a lot of them are 20 or 25 out of 25. So having it written down and agreed is where we start, not where we finish. And I think the key pushback, I think, to the executive then is to say, what are the mitigation plans around this? How do we take the 10-year plan and mitigate these issues? We haven't got a lot of extra money, but how do we use capital? How do you use the money we've currently got to mitigate these risks? And particularly when we look at the delivery plan, let's use this as an input into the delivery plan to say what actions are we taking and over what time frames do we expect these risks to be mitigated, so that we can come back in a year's time and say that was 25, it's now 20, it's now within our risk tolerance, what progress we're making. Otherwise this becomes a document that sits on the shelf, or we talk about it every 2 or 3 months, but it's not actually serving any use. So my challenge back is to say this is the start, not the end. It's a good piece of work, but let's now use this in anger to drive some real change.
So, Jeremy, as the chair of that committee, how would you like to see that happen?
So I think I would really like to see a delivery plan against a 10-year plan, and I'd like to see that delivery plan then converted into a plan against each of these areas to say these are the actions we're going to take. Some will be qualitative, some will be quantitative, and these are the measures that I think that we're aiming for within the year, that we are aiming for to say this is how we've got this from 25 to 20, and then I'd like to see each of the committees, not ARAC, the committees manage those outcomes, and then we can look at the overall process around that to say checking. So ARAC will not take responsibility for cyber risk or workforce management, but we'd like to see the other committees making sure they're taking those actions in place and mitigating the risks within the committee structures. That would be my proposed approach.
So I'd strongly endorse that, but also going back to David's point on this being live a month ago when talking about industrial action, and there'll be other risks that pop out and all of a sudden become the real big thing for us. So how are we going to have this as dynamic as that, and how are we going to work through that, David?
Well, I think we currently work on a quarterly basis, but I think given some of the live risks, John and I will maybe keep a closer eye on how we report this, obviously up to the board. We don't want to be changing it regularly every month. I think just going back to the live comments to your points, Jeremy, when you look through that operational risk register and the strategic one, when I think about all of our last executive meetings, it is all this stuff that we're talking about and the mitigation. So you're absolutely right, we need to find a way to capture that. The 10-year plan, which of course we're going to come on to talk about later, the 8 work streams underway, I think it's important that these risks are highlighted and triangulated in the way you've described. So we'll get those groups to help us do that as well. So you get both things. Absolutely. And it's a pointless document if you don't make it feel live and real. Absolutely.
Thank you. Mark?
Could I reinforce something from Jeremy and reflect back to the amazing work that's been done around finance and financial performance? A lot of these risks are behavioural in nature, and it's if I take cyber or the ability to take advantage of digital technology, a lot of what holds us back today is too much choice, a lack of a coherent view, and a lack of a collective belief about what wants to be delivered. That's really a cultural issue, not a technical issue or a cyber risk issue. And I would love to see the level of really, really good performance you've had on financial and the belief driven into the system about we're going to compromise on this because we want the overall result to then be reflected across the risk register and the delivery register as well.
So I think one of the things that we need is that, as you said, Jeremy, is the risks allocated to each of our different board committees, so that we can go into more detail in those, and then fully aligned to the executive committee so that we can get assurance that they are being systematically looked at and with clear mitigation plans. Because some of them, I think I know where they're picked up, some of them I'm not fully sure. Exactly. So I think that feels like a key action. So when is your next audit and risk?
Next week.
Okay, great. So look forward to seeing that the week after.
Anytime like the president. That's right.
Okay, good. And thank you, John, for the work that you've done supporting that. Okay, good.
Can I just raise one point about the dates for the target score that we're aiming for? I assume not all of them are at the end of the financial year.
No, correct. They're not. So actually, I think what we'll do on this is include the appropriate committee, be it executive or board, where everything falls in, and then just the expected dates by quarter that we would expect the mitigation.
I do think for future planning, Andrew, I think it'd be really useful to align what the annual plan is with the financing and then with the risk mitigation, so that the whole thing is joined up. Otherwise, from a management point of view, it gets very hard to work out the different timeframes, and the timeframes can then tend to slip, and you never know. Even if it's these 5 things is what we're going to do in the year, we can then agree all that as a board, as that's what the prioritisation. It just helps with the whole process. So I would ask that for next year's planning cycle, we add the risk mitigation and the resource required against it into the planning cycle, so that there's at least some timeline against which you're measuring it. That will change depending on the circumstances, and it should be a fluid plan, but at least we're all working to an agenda, and we can use that as a prioritisation model within the budgeting process as well.
No, understood. Noting that things like industrial action,
sideways, a plan is a plan to be changed, but at least you've got a plan.
Yeah. Okay. Good. Winter planning. Sarah Jane.
Thanks, Penny. As Jim said in his introduction, winter planning in summer. So the first thing to say about the winter plan is it's really embedded in what we do all year round in UEC. One of my favourite phrases is UEC is definitely all year round, not just for Christmas. So we have to be interested in it every day, because it's the underlying systems, processes and delivery that goes on throughout each part of the pathway that we need to be able to escalate during a winter period, not pull out a completely different way of working. So the starting point really of this is making sure that the things that we said we would do in 25-26 we do. So very much in line with other conversations we've had in the board today. We've got trajectories that we're tracking really closely in terms of progress on Category 2 response times, 4-hour performance, 12-hour performance, and also, as David mentioned, the link there with the handover delay, given that can be such a big driver of Cat 2 response times. So that is an everyday job, and that's the foundation stone of our winter planning. But clearly on top of that then, we need to be able to escalate, both in terms of our the capacity and the ways that we work, but also our ability to be able to respond and make decisions in a timely way, because both of those things are really important when we come under pressure. So we have worked with colleagues in the system to design the way we do winter planning this year. We've had 2 sessions in 2 of the chief execs meetings, and we've also worked with chief operating officers as well to say, how do we enable you to have the best conversations you can locally about what you need to do? So we've got some structure and some sharing of important practice, but we are not weighing people down in lots of requirements to fill in templates and spreadsheets, which is really important, because there isn't really any template that gives us assurance that's really the thing that's going to help those systems with their winter plans. So earlier in the week we shared with colleagues across the system the way that we're approaching this. We're asking people to do their winter planning over the course of the next few weeks based on the UEC delivery plan, the 25-26 delivery plan. That sets out really clearly what makes for a good, effective UEC system within the constraints of how we work now. Obviously, we're waiting for some of the more transformational change through the 10-year plan. So organisations work through that now. We have produced one for ICBs and one for trusts, a board assurance statement, and that sets out the key questions that we are asking the chairs and non-executive directors to ask of executive colleagues. It's deliberately written in an assurance way. We've also provided some prompts that can be followed up around that. So we're asking that happens over the course of the next few weeks. And then at the beginning of September, we are asking system and trust colleagues to come to a series of regionally led stress testing exercises where we're going to use more of an approach that we would use in EPRR to actually test whether those plans stand up to 3 different scenarios that we have designed, a kind of moderate, well, we're going to get winter no matter what, but a sort of moderate scenario, a more severe one, and then an extreme case, so that we're clear that those plans are resilient, not just in terms of the capacity that they build, but in terms of the response and the way that the system and trust work together, given we're in a change of operating model here. We don't want people to suddenly be unsure what to do, the third week in December. We want to test that out in September. We're then asking people to go back, learn that, ensure that they capture the lessons, and then sign off the board assurance framework and return that to us by the end of September. I am confident that it only takes you 10 minutes to complete the framework. It's going to take quite a long time to really do the work to know whether we can provide the assurance statements or not. Now, there are a smaller number of organisations, I think this links to Andrew's point, what are we doing now, that we know will find this really difficult. They've got challenging UEC performance now. There's hospitals with ambulances outside for multiple hours now, or with patients in corridors now, before we even get to winter. So in terms of our approach there, it's twofold really again. One is just to make it absolutely clear through, again, chairs, also chief executives, that the things that work. They work in the places that get good performance. We all know what they are, and what we are looking for is that consistency. That might be my phone. What we're looking for is that consistency in the way these things are applied. Basically, we need delivery of your own plan. So part of it is about, we really need to own this now. We need to see progress every day. But the second part of that is many of these organisations have got quite profound challenges in terms of some of the clinical models of care. And therefore we've changed the way our improvement teams work this year to be able to give more dedicated and focused support to organisations with the biggest challenges. So we will be deploying colleagues from ESIST for the Emergency Care Intensive Support Team for at least 3 days a week over a 6-month period, so they can guide some of those clinical teams through the changes. Most of the people in ESIST are clinicians themselves, but they can guide organisations through that. But I will keep a close working relationship with those chief executives and board members as well, to make sure that they are following the advice of ESIS, because sometimes we've got really strong suggestions of what needs to happen and change, but we don't see it. And Jim and I then have been reinforcing that message with chairs and chief execs as well. So it is in a way, it's that combination of hands-on and hands-off simultaneously, isn't it? We're taking a step back and allowing people to do this their way, but we are saying that this is about really testing, responding and being honest with ourselves and taking corrective action, rather than feeling assured by a big document with loads of ticks in it. Thanks, Penny.
Okay, thank you. So I've got Mark and then Mary.
I just wanted to add, obviously working very closely with Sarah Jane and the sessions that Sarah Jane described with the chief execs last week. We did them together, didn't we? Because we want to reinforce the message that the plan is not just about the urgent care performance delivery, it's also about keeping plans on track that we have for RTT, waiting list and for cancer as well. So, and we know quite a number of organisations have built that into their plans, very sophisticated plans of this year, and others are still got some modification, I think, to do to make sure they're trying to bring as much work forward in the months where it's more protected.
Okay, Mary?
I really wanted to ask what we're doing about discharge planning in order to get this to work, because I'm aware that, as you've said, there's such variability across the service. But my belief from some trusts is that if you could get discharge planning right by somebody doing it every day right across the acute trust, you would free beds that would then enable A&E to cope and get ambulances back on the road. So is there a criteria that we're really pushing people on that?
Yeah, absolutely. Both in terms of the discharge that the trust, the organisations themselves own, which is the pathway that the majority, 86% or so of patients leave on. So do we understand the standards for that? That's one of the questions I'm sure some boards will be having lively conversations about. But do we understand the standards for that? And is that appropriate, especially at the weekends? Because what we tend to see a tail off in the number of patients discharged, which is why we get the problems at the beginning of the week. So that's something that we all need to own. But then in terms of the other pathways where patients need to leave hospital with support, do we have a completely shared understanding between the trust, the community service, local authority and social care providers about how that should be happening in normal time, so what should be happening today, but how in each of those 3 surge scenarios we expect some of those to also ramp up as part of this. And that was one of the questions that we tested through the Better Care Fund planning process this year, so that there is an understanding of what we are expecting to happen that's shared. I agree with what you're saying, Mary. Often this gets identified as a capacity issue when it's really related to a process issue. Whether that's a clinical process issue or a handoff issue between different parts of the system. So the one thing we ask people to really focus their attention on is not just the number of patients in hospital that don't meet the criteria to reside, delayed discharge, but the days that then pass from the day that they're ready to leave. And the drive is to try and get those down. Even if we can only reduce hours, it is the thing that creates flow. But if we can get the patients that are going home on home care out within 24 hours, that can make a huge difference. So it's not trying to do really heroic and impossible things, it's trying to standardise the work and sort of reduce for each of the pathways over a period of time. So it's definitely a key part of this, and we've asked, as part of the assurance return, for the Trust Board to understand their role in that, but for the system to understand how it all links together, and in particular how it's coordinated with local authority and social care provider colleagues. And that includes for mental health.
Yeah. So no, Claire and Ben want to come in. Just a quick question for me. How far off are we having all services available 7 days a week?
Quite far.
Why?
There's significant... it depends what services. I mean, most hospitals now have got the ability to do the core decision-making 7 days a week in terms of moving people forward on the P0 type of pathways, although not as robustly. Sometimes there's only one ward round or one review through the day rather than 2, for example. But quite a lot of the other support services that sit behind that, the really important clinical support services, are less available, whether that's some of the routine therapies, for example, or some of the social work assessments and so on. Things do tend to tail off on a weekend. So I think Megan is not here today, but one of the things that she is going to lead is a piece of work on some of the things that we've done previously around 7-day services, and is the more that we now should be doing, certainly to standardise the things we would expect 7 days a week. Clearly there are really big trusts that are sort of closer. There are smaller organisations that are where things are challenging, but what we always say, certainly when we do our improvement interventions, is control what you can control, and if you keep your P0, your non-complex discharge going, even if you reduce down to 70% or 50% of what you normally do, that will be enough to maintain. But we can't have a tail off where we only have single figure patients leaving hospital on a Sunday, and that does happen sometimes in some of our most challenged providers.
Okay, so can we keep an eye on that?
Yes.
Because some of this is, I recognise local authorities aren't within gift, but community services certainly are, primary care ought to be, and acute trusts certainly are. So a bit about how we keep an eye on that.
100%, yeah. One of our key things again is we should not other problems away here. There's always things that other people could do better that aren't us, but we don't other it away because it's our problem to solve.
Okay. So we've got Claire and then Vin and then Andrew.
So it's partly to just to carry on from the point you've just made there, actually. So at the Chief Exec event last Thursday, for the first time, we had a significant number of GP leaders in the room involved in the winter planning, which completely alters the conversation around the way you have. So when we look at, again, coming back to the performance pack, although the numbers reflect on performance within the hospital, it's part of a dynamic system, and so the more we can actually start to reflect that the proactive care and the planning bit, and how urgent care, the majority of urgent care actually doesn't happen within a hospital building, the more complete picture we will get. But I think it changed the conversation by having different people in the room on Thursday.
Good. Ben?
Yeah, so obviously one of the most important things is discharge is actually everybody in the multidisciplinary team having access to the same data. So one of the earliest tools we developed in the Federated Data Platform was a platform where you could see all your patients, regardless of whether you were a resident doctor or a discharge coordinator or someone working in social care. Everybody could see where those patients were and where they are on the journey. I haven't forced it on people because if you've got a good discharge system already, you don't need it, but it's available to any trust in the country who wants to use it.
What impact's that had?
So in the trusts where it's been used, we've seen a sort of double percentage point reduction in the numbers of patients who've been in hospital for longer than 21 days where they've used it. Now, obviously, the two things are connected because when you have data, you also redesign your processes, but we've seen that in a number of places.
So how do we get it into all the hospitals?
Well, Sarah Jane and I work closely together because we don't have foist tools on people if they've already got it, but where people haven't, it's available and we can work with them to implement it.
Yeah.
To that question, do we have a correlation between the maturity of adoption of the Federated Data Platform and trusts that are struggling operationally? Because having seen some very, very good trusts with very high levels of adoption, intuitively, that seems to be true. Have we actually laid it out?
There's been no study of that specifically, Mark, but I am absolutely confident that it's the organisations that are using data and have a systematic approach to the way that they're controlling across pathways. They can see each other's data and so forth. I mean, the best example of this is Maidstone and Tunbridge Wells, their control system, and so I mean it's absolutely exceptional. I can see some of my chief exec colleagues looking at me saying, "No, my hospital, no, the amazing." I mean, other hospitals are amazing as well, and I'm sure there are many others. But anyway, yes, that's a brilliant example of how data has absolutely transformed, right down to knowing that a bed is being cleaned and is going to be available in the next half an hour. Therefore, a patient can be pulled through and waiting to go on the ward, but. Not all of those systems do use the Federated Data Platform, which I think is Vin's point, is it may be unwelcome at this stage if we were to...
Yeah, if you've got a good system, we wouldn't force it on you. But if Sarah Jane's team identifies somewhere that's not using data, there is a tool that's freely available. You don't have to purchase it, that can be used.
So it comes back to what are the top 10 actions?
Yeah.
And how do we make some of them... unoptional.
We have a top 12 action list, which we, in our better performers, we see people do, and this is what eAssist essentially take that to people and start working it through with them. But yeah, there's quite significant cultural issues in quite a lot of these places that struggle to implement what works.
Okay, but there may be something about, and we'll hand over to Andrew, but if we've got a list of the top 12 actions, if we could identify the trusts that are not adopting those, then I think a phone call from Jim to the chief exec followed by a phone call from me to the chair might make the point that we absolutely expect them to adopt the top 12 actions.
And we've shared them directly, haven't we? Jim and I met with a few chairs and chief execs, and part of that was actually explaining that these resources were there and our expectation was that they were being used because they do work. I know people are always looking for silver bullets, but if you align your staffing to your demand, which I'm sure is going to be Andrew's next question, then I can preempt. Then that works.
Another one there.
Who knew?
So I think this is a really good opportunity that we've given boards to really, button down what the arrangements are for the winter, and having to sign this off prompts a whole series of conversations, which is the best way that you can kind of reinvent this that I can think of. Really brilliant idea in terms of getting boards to have that debate. And being on a trust board, I know that this conversation is being taken very, very seriously. So there's some big challenges in here, including the senior decision makers on the front door, which I've got to think about, which I think most organisations will debate and work through. So the chances are that this will elevate to kind of the top of the list or second top if finance is the biggest challenge in a particular organisation, which is a really welcome kind of innovation. So well done for that.
And it did genuinely, it's a piecing together of some things that we've learnt from the elective programme, but a big part of it was actually the chief execs themselves saying this is how we do X, Y, Z in our organisation. Like the idea of the planning on the 3 levels came directly from something that a high-performing trust does. So I think it just shows the power of kind of co-designing, and I was able to send this out 72 hours after the chief exec's event to say, look what we've designed together essentially. So it does sort of hopefully changes the way it's been received. I haven't had a complaint about it yet, which is unlike any other correspondence I've sent. I'm sure I keep asking every day, has anybody complained about it yet? But not so far. So I think hopefully it will be really helpful.
Okay, great. So it'd be good to see at the next board meeting, which will be in early autumn, the list of organisations that haven't adopted the top 12 action.
Yeah, absolutely. Penny, we can perhaps align that then with the performance data, because we tend to be more stressed about that if there's not performance. If people have found a different way, then...
Yeah, absolutely. But that in itself, it would be interesting to see. Yeah.
100%.
Okay, good. Pandemic preparedness?
Yeah, so just perhaps this be a little briefer, Penny. There's just a couple of things I want to highlight. The first is that the colleagues in DHSC are leading an overall pandemic preparedness programme and a series of sort of sub-pandemic response plans for various different respiratory or airborne pandemic scenarios. We're obviously working closely with them as partners, and the first one of those, which is focused on respiratory, is the first that will emerge. It obviously very relates to the recommendations and the early sort of conversations and findings from the COVID inquiry as well. So it's a really important document, and it remains one of the highest risks, I think, overall on the government risk register. I guess where we have that particular role is that we are testing our own ability to be able to respond in a pandemic scenario, and there is a big cross-government exercise due to take place from September to November called Exercise Pegasus. So it's a tier 1 exercise which will involve ministerial participation, COBRA activation and so forth. It's led by DHSC and UKHSA, but we're really important partners in that, and we've committed that several members of the executive will fully participate in that. One, so we can test some of our own plans, but also we're going to learn a significant amount. We had a warm-up exercise, Al-Karab, a few weeks ago, which some of us attended, and there was significant learning just from that warm-up exercise in terms of sort of the resilience of some of our plans and responses based on all different sorts of flu scenarios. So that is due to take place. It won't be a heavy burden on the NHS itself, it's more testing NHS England scenarios, but I think it's really important, one, the board's aware and that we show our commitment to it because it's such an important exercise, but also we put a flag in needing to bring our lessons learned, and increasingly as we come together with DHSC, our risk register that we hold between us at the moment is quite lively, I think would be the way to describe it, in terms of some of the things that are ongoing risks should we face a future pandemic scenario. I think it's really important that we bring those together, that this board has full sight of the areas, and like I say, I think a good moment to do that will be once we've done the exercise and we can test whether our current understanding of our ability to respond is borne out as the exercise progresses.
Sarah Jane, one of the issues in the last pandemic was the indirect impact on children, but if we have a pandemic that has more of a direct impact on children, our ability to stand up PICU capacity is different to that in terms of adult ICU. Are we confident that this will test scenarios on children specifically? Because I think that's probably one of the areas of concern that we would have for a future pandemic.
So I don't know the scenario because that's part of the going into it. That's the idea of going into it cold. We have got someone from here that's part of the group. The warm-up exercise did involve something that was actually having a disproportionate impact on younger people. And the exposure that created was really quite clear, not just in terms of our services for children and young people, but also in terms of our workforce. So I would be surprised if it didn't, Duncan, but I think either way, that is one of the things that's quite high on our risk register as of concern.
Okay. Let's take other questions. Robert, Ben?
So 2 questions, Sarah Jane. One is, those with a long memory will remember exercise sickness, I think it was, which was about 15 years ago, which was a pandemic simulation. It gave some false reassurance because it was very much based around flu, and of course the custard thing about COVID was it was transmitted before you're symptomatic. But I just wonder if there's any lessons learned, that someone's got a corporate memory of how sickness went and whether we could improve Pegasus as a consequence. The second question is, one of the commitments I recall being made as we emerged from COVID was that some key infrastructure, namely vaccine manufacture capacity and test and trace capacity, would be preserved, not at the scale that it was needed, of course, during the pandemic, but it could easily be dusted off and re-expanded. And I just wonder if you can reassure us that some of those bits of infrastructure have been preserved.
So on the latter point, this is a piece of work that we're doing with the department in preparation for the exercise, which is what would it take to stand up some of those responses, and what would be the timeliness of those given where we are with the remaining with the infrastructure that we had. So I can't give you a confident yes, but I can give you an absolutely that's hugely on the radar. And I began meeting regularly with Catherine Francis, who's the kind of counterpoint in the department, to make sure we've got the same understanding of what the absolute number one risks would be. And as for the corporate memory, I don't recall that specific exercise myself, but yes, because I think one of the things that has caused a big acceleration of this is it has been so long since an exercise like this has been undertaken. So things have been looked back on to say what are our particular risks and exposures, and that's gone into the design of this exercise. As I say, it's been designed by a series of experts, but not those who participate are not clear what it is yet.
Thanks.
And then Jeremy, and then Jim.
It was a question, really. So one of the things that we had to do during the COVID-19 pandemic was actually significantly upgrade our data systems, because until the pandemic came along, for example, we didn't have an end-to-end tool for looking at the whole end-to-end vaccine supply chain. I just wondered, because it's not in the paper, whether any of these are going to look at our data infrastructure and data requirements.
Right, let's take the other question. Jeremy?
Yeah, so having just been through a massive cyber incident at M&S, it'd be very remiss of me not to say this is great, but it's probably one for DDAT to have a think about. A similar exercise around cyber that involves not just NHSE but ministers, other third-party groups. I think I would just say you can protect all you like, but until you get to the DR side of it, you don't know what you don't know. So just a thought that if we can do something like this, something similar on cyber.
Jim, do you want to update where we are on that?
Yeah, so firstly, they've just done an exercise in the southeast region, not involving ministers, but doing everything else you've described. And then as part of resilience planning, last year we wrote out to all resilience teams and said there were 7 scenarios we wanted them to exercise over a fixed period, and one of them was a cyber outage. The particular one of interest in the southeast was they looked for the impact of a prolonged outage. As a result of a cyber attack, because of course, as you know, and as you found in Marks and Spencer's, you can't just deal with a cyber attack and switch the system back on. It can take several months to rebuild it. So your resilience planning needs to cover several months of disruption, not just a short period.
So what we're going to do is we're going to take that southeast, which is effectively a ransomware simulation, take the lessons from there, and then come back with some recommendations about what else should be done.
That was going to be my follow-up point for this and for that, to feed those recommendations back into the mitigation plans and the risk registers. Otherwise, again, that's an exercise that's going on outside.
Yeah. I mean, I think this is flagging. We need to come back on this with quite a few things. So I think you want to come in, Tom, and then I'll go to Jim, and then we'll finish.
Yeah, I just wanted to ask about what the definition of success is in terms of managing the response. So in the Darcy investigation, it highlighted the fact that the NHS was a real outlier in terms of the amount of routine care that was cancelled during the pandemic by a very significant degree. And so when you have an exercise like this, would it look at the ability to manage the response to the pandemic threat but will it also look at the consequential impacts on routine care and the overall health and care for the population? That's the question.
So I was going to make partly the same point. Many of us will remember vividly forever the experience of that, the build-up in sort of February, March 2020, and then when it kicked off. And from my point of view, there are three things I would have always hoped that were better next time than last time. So one was the absence of PPE, especially gowns. Never forget the fear of knowing that we didn't have any and being told that we wouldn't have any at peak time. Our inability to test. And again, relative to other countries, that we were unable to mobilise quickly to test a testing response. And then also, as Tom's just said, the broader impact and the frustration of seeing the impact build up whilst activity was curtailed, out of line with other systems. There's got to be some learning in all of that. So we've got the inquiry, we've got all kinds of other processes going on. For me, I need to feel more assured that if this happens again, which it will at some point, we're better prepared than we were last time.
Yeah.
Just briefly, Penny, it definitely looks at wider societal and wider impacts than whatever's immediately presenting as the issue. And in the warm-up exercise, this was a huge issue because society's response would clearly be very different based on having been through a pandemic previously. So even the sort of starting point of it became quite problematic. Children in school, there's a whole range of things. So it definitely goes broader. As I say, I'm not sure what it is. To go to Jim's point, yeah, I mean they're I think the key things we're having conversations with DHSC colleagues about, and in particular whether there are things that we should be doing that are no regrets anyway, because as you know, part of the issue with testing was we weren't networked sufficiently between different laboratories. We don't have the data flows. We can't test a group of people here and get a result over there, which is actually just inefficient pathology service anyway. So are the things that we could be doing to make the NHS better every day that would also make us better in a pandemic, and can we prioritise some of those? So they're some of the conversations we're having. I just make one point just to loop back to where we started on capacity to do this test, which is clearly critical. I've talked about the September exercise, we've talked about this one, we've talked about a cyber one. The team of people that would be doing this are currently now doing the industrial action, and they will need to continue to do so whenever. So we just need to take into account as well that will impact on our ability to be able to thoroughly do all the different things that we would want to do in terms of exercising. But whatever the case, we'll make sure we prioritise this 100% as per the risk register, because we doesn't matter what else is going on, if there is an emergency, we still have to be able to respond no matter what the underlying situation is. So we will do that, but it does stretch. It does, doing some of these other things that have been described, become more stretching.
Jane, did you?
It was just a brief point, just to say, I think there's always a danger of fighting the last war, isn't there? And, I think that WHO is picking up thousands of potential emerging threats every month. We don't really know what the next pandemic will be, just that there will be one. And I would just encourage us in this exercise, and I remember I was sort of on the fringes of Operation Cygnus. I think there's a danger of the exercise of just saying, does it respond to everything coming out of the COVID inquiry, instead of casting a mind and saying, does it respond to everything that might be out there? So I would encourage us to proactively engage with and look at countries that have done really well on standing capacity, like South Korea, and not just narrowly think, let's address the issues that are raised out of the COVID inquiry, but actually look out into the wider world and say, who are the people out there who are really good at looking at sort of standing capacity for any emerging threats, particularly zoonotic ones.
Okay, so let's not preempt this. Thank you for taking the leadership on it, and thank you for joining the exercise. I think almost the most important point you've made is that we have a team of people who lead all of our work on emergency preparedness, which covers many things, including industrial action. And that team has a lot on their plate, which sometimes we forget. It's sort of in the background until till there's a crisis. So thank you to you and everyone else for doing that. But I think it's something we need to come back to and pick up on that later. Tom, 10-year health plan.
Thanks. So, chance for a verbal update. So there isn't a paper for this. So I'm just going to run through where we stand. So the 10-year plan has obviously been published, and we're now working to maintain and build momentum for delivery, working in very close partnership with our colleagues at the Department of Health and Social Care. The most important message is that our approach to delivery is consistent with the things that we've said in the plan itself. So the plan envisages a devolved and diverse operating system. What that can't then mean is issuing a series of instructions from the centre about exactly what everybody should do at every moment in the coming decade. And so in terms of the principles that are informing our approach, the first and most important one is that this is a collaborative effort between the centre and the service to take forward the delivery planning. We're creating protected time and space for teams to focus on it, particularly during July and August. We're maintaining the urgency and the discipline that you would expect with weekly planning cycles and a clear deadline set for early September. And we're encouraging broad-based participation in that delivery planning process. So, for example, as Claire mentioned earlier, we had our primary care colleagues, a number of them in the room at the Chief Exec's event last week. So in terms of our overall approach, we have a joint governance arrangement with the department. So it's one team, one approach to the delivery planning. And then we've got a division of labour in terms of the different work streams as to who leads on what, which makes sense according to the scope of responsibilities and the skills within each area. So there are 9 work streams in total. The department's leading on 3, so they're leading on life sciences, prevention and legislation. And then NHS England is leading on the other 6 work streams. And I'll just give a brief overview of what's in each of those 6 work streams. The first is neighbourhood health, which the immediate priorities include designing the model, contracts, payment reform, financial flows, workforce, digital estates, all of those issues, trying to get them together and say not necessarily what is the complete answer on each of them, but what are the starting things, how can we get moving on each of those different important areas, and selecting the 42 places for the National Neighbourhood Implementation Programme. The next is the financial foundations and medium-term planning. So we're going to publish the new 3-year planning framework in October. There's a lot of work already underway on the reform of block contracts and the development of a neighbourhood tariff. There's work that's going on delivery, delivering the model region and the ICB clustering arrangements that Glenn is leading. On digital and data, we have a work stream that's the NHS app and the single patient record, where the immediate priorities are to launch the user and supplier engagement and complete the business cases for 2026 procurement by the end of this calendar year. On quality, it's a big and important work stream we've already touched on in the discussion today. There's the revamp of the National Quality Board, the creation of a new quality strategy, the development of modern service frameworks for CVD, mental health, sepsis and cancer. And then the big discussion that we had, that David led around this real focus on transparency. We're also, as we picked up on a little earlier, rolling out the maternity outcomes signal system, MOS, to try and pick up on issues in maternity care as early as possible. The 5th work stream then is Oversight, Model FT and Model Integrated Health Organisation. So we've launched the performance segmentation, as we've talked about. We bring in more public league tables, and we have a kind of national improvement offer that has been developed. We're finalising and developing the revised Foundation Trust licensing model, and the other priorities include the kind of early scoping of what this integrated health organisation model will look like and what it will take to become one. And then the 6th work stream is on workforce, where we've committed to developing and publishing a new 10-year workforce plan. We're publishing nursing and midwifery strategies for England, focused, as we talked about a bit earlier in the context of industrial action, improving staff and student trainee experience. That's not just for resident doctors, that's more broadly across the workforce, and then making sure that there is an alignment between workforce, service and financial planning in the medium-term plans. At the NHS leadership meeting last week, we had obviously the CEOs, we also had primary care leaders, and we asked for volunteers to come forward and say who would like to be involved in planning, delivery and contribute to those groups. And so far, we've had 150 expressions of interest, and I think that really speaks to the point Jim was making at the beginning about the real ambition and appetite and enthusiasm that exists out there in the service. They want to grab hold of this and run with it. And so I think that's a really good indicator that it's not just us saying that we want to bridge the gap between the centre and the service. The service wants to do exactly the same thing. And so I think we've got some really strong momentum there. So we'll be working at pace over the summer so that we really get into the autumn, going at full pelt. And we'll be able to update the NHS leadership community as our event that we have planned in mid-September, where we'll bring everyone together and we'll be able to share the progress that we collectively have made from the contributions that the people within NHS England, DHSC and all the leaders out in the service who've come together to contribute to that process. So that's a bit of a brief update on where we stand, and I think Claire's going to describe some of the progress that we've made on neighbourhood health in different aspects.
Thank you, Tom.
Claire.
So, not that I'm competitive, but of the 150 people put an expression of interest as which work stream they want to be involved in, the most people were interested in working with the neighbourhood work stream. So I'll let that hang. I think one of the bits that's really important and exciting about the plan is, so we have spent a lot of time here today talking about activity and performance in hospitals, and that largely impacts upon adults. The thing that's really exciting about the plan is actually most of the plan is about activity that doesn't happen in hospitals, and actually we start to talk about more vulnerable groups. So we've launched the Neighbourhood Health Implementation Plan this week. We had 1,400 people on the webinar. I have to say my phone is going crazy with people going, we really want to do this. I think we are going to be inundated with applications, which is a fantastic position to be in. We've today opened our first 24/7 mental health crisis centre in Tower Hamlets, and again this is hugely important, just so in terms of people with serious mental illness, they're some of the most vulnerable people in our society. And what we're doing in these mental health, 6 pilots across the country, and what we're doing is actually bringing together services that will support people across all of their lives, not just from the physical and mental health. So we're actually bringing together employment support, debt support, and actually helping people live their lives in the communities in which they are. And I think the other threads that go through, particularly, we haven't talked that much about mental illness today either. I think it's really important. So we've got the 6 hubs, we've got the 24/7 access in EDs, we've got the mental health crisis line, and actually the mental health modern service framework. And the modern service framework refresh has been so well received by the clinical communities. You can see people are really keen to define what good service looks like and how we can actually drive consistent improvement. But the modern service framework for mental health that will be led by Adrian James, our medical director for mental health and neurodiversity, is going to start focus on serious mental illness as well. So I think it is a really exciting plan, and I'm obviously particularly excited about the focus and the progress that we're already making around neighbourhoods. So thank you, Tom.
Okay, so great to hear. Just want to check, we will still be seeing a detailed delivery plan by the beginning of September?
Yeah. Yes.
Okay. And so a quick question then, Claire, how can we launch an implementation plan when we haven't yet seen a delivery plan?
It's the implementation of the yes, all right. It's the P can be is programme. It's the implementation programme for the National Neighbourhood Health Implementation Programme, which will focus on multimorbidity. So that's the programme being led by John Oldham via the task force that will lead us across the 42 places across the country.
It's more of an improvement collaborative, isn't it, in lots of ways?
Well, it is, but we're focusing on it's focusing on multimorbidity, because actually if you can fix multimorbidity across a place, you've got to bring together acute community mental health.
Well, maybe we should call it that then, because otherwise we're going to confuse all of us. So if we've got a specific chapter on neighbourhood healthcare, and we're going to see a very detailed delivery plan by the beginning of September about how we're going to implement that, I think we need to see what that is. And it sounds like this is something a bit different.
It's okay. P is for programme.
Yeah, okay. Ben?
So one of the work streams will be on innovation, life sciences and research. So just for noting, I think the life sciences sector plan was published by the government yesterday. It's got a number of commitments in it because we developed the chapter in the 10-year plan together with our section in the life sciences sector plan. It's got a number of commitments to improve research, being the best place to grow and scale a business, and also making ours, the NHS, better at regulation and speeding up access for innovators. So we are doing that together, so we don't have two separate plans. We'll have one plan jointly across science, innovation, technology and the department.
Great.
I think this is really exciting, and it won't surprise anybody that I'm delighted to hear about the focus on acute mental health services. But I'm very aware that this will require transfer of some income from acute trusts to neighbourhood services to make it work, because the argument has always been 20% minimum of healthcare is mental health, but only about 8.5% of our budget is spent on it. So if we're going to get there, are we working in tandem with how we start to work that through?
Yeah, absolutely. I think, Tom, you highlighted when you run through the neighbourhood health bucket, but and yesterday, actually, I met with all the CFOs. It was a virtual meeting yesterday, and the question they had was, I think I had more than 150 volunteers. Oh, here we go. But they were in person.
148 were from Glen Burley as well.
It was actually 148 on one topic, which is Glen. But in all honesty, the CFO community was saying, well, how do we enable it? And people are talking about stranded fixed costs and all the usual things that you would expect. That's why actually unbundling and understanding what's in the UEC bucket, as we're calling it, is so important. We will have a piece of work we shared yesterday at a high level. It's going out in the next 2 weeks. Week by week, we're going to have to be doing this in with the service. We can't do it because there's local prices and all sorts of things within the financing model. So huge appetite. Everybody wants to be involved as much because they want to influence it, in all honesty, as well as to be part of it because they're feeling excited. But in all honesty, though, I think Penny and Jim have had some correspondence coming through a bit anxious about the amount of financial change and disruption you can take in one go. So I think we've got to do the work, see what it says, step back and see how much risk we can take, and by then we'll be at month 6 in terms of the numbers as well.
But we've got to, 20% of activity doesn't mean 20% of spend. We need to understand what things should cost, which is like that.
I want to support what you're saying, but also acknowledge that actually, if some of those mental health issues that are currently dealt with in ordinary A&Es are dealt with in a different way, it will actually be very cost effective for acute trusts as well. So, got to get it right, haven't we?
Yeah, just to add, I think as part of the financial modelling for applicant acute new FTs, we would expect them to be looking at the impact of left shift in a variety of ways.
Absolutely. Again, that's something we'll need to come back to, is what that evaluation framework will look like. I presume that's sitting with you, Glenn.
I've had lots of volunteers to work with.
Okay, we'll have that as a new performance metric, David, for the exact team. Popularity contest. Okay, great. Let's move on to Freedom Speak Up. So thank you, Tom and Bethany, for joining us. Want to give a high-level summary of the paper?
Yeah. So, hi everyone. So, 3 reflections I'd like to share from the Internal Freedom to Speak Up report. We launched a unified Internal Freedom to Speak Up service just over a year ago, and it's been good to see that so many people have felt able to speak up and use that service. and significantly more numbers than the previous year. However, their experience when they speak up is variable. And so only 40% of those who speak up say they would speak up again, and those who have used the service and have provided anonymous feedback indicates that while support from guardians is really valued and welcomed, the response received from the organisation and from leaders is not always the same. And that is really important in the context of, I think, a staff across NHS England who are probably feeling a bit more fragile than they might be going into further organisational change. And I know that's something raised with you, didn't they, Jim, when you spoke to the Guardians recently. And so clearly it's really vital that our staff feel listened to when they speak up. And so really high quality leadership and management is essential. Unfortunately, leadership behaviours are sometimes part of the challenge and part of the problem with the cause of what causes people to speak up, both in terms of the response they get when they try to raise issues, but also in terms of maybe not feeling able to raise things in terms of the environment that's created by leaders. And so setting the right expectations around those behaviours, and also ensuring that our leaders and managers recognise the value of what people bother and feel it's important enough to speak up about, and really value what they have to say and listen compassionately and respond fairly. So those are the three reflections I wanted to share. What are we doing to sort of improve and take things forward? Well, one, we're improving our processes to make sure that we are maximising opportunity for effective resolution of cases. Two is working more with senior leaders across the organisation, and in conjunction with HR and OD colleagues. And then the third thing is about making sure we do more to capture and share the learning and improvement that follows from speaking up, which creates that loop of encouraging more people to come forward.
Yeah. Andrew, I'll ask you to come in. Question: where people feel that their concern hasn't been listened to or heard or resolved, do we know why? Do we know sort of what hasn't worked?
I think initial listening is actually genuinely understanding what it is the person is saying and why they're saying it. If they don't feel listened on, sometimes what happens is that becomes as much part of the problem as the original issue they're speaking up about. And certainly when, say, I get drawn into cases that might get escalated, those are the things that I'm trying to bring out. And also, I think, engaging senior leaders really early in trying to work out, okay, how can we move this forward?
Yeah. Okay.
So, I mean, on this, we still haven't got the culture right in the organisation, and we've had, I think, two kind of attempts now. When he and I came together, we said we were going to have a kind of cultural reset. We said exactly the same with the last restructuring. And I think it's really important that as we go into the new world, that someone leads on the work on culture. And we just haven't bottomed all of the behaviours that we expect to see. They don't kind of translate into taking this subject matter really seriously. So in a contrast to a trust, where the focus is on resolving things quite quickly, here we've had cases that have gone on and on and on, and despite Tom's valiant efforts to try and get people leaders to get involved in resolving issues, these things just go on and on and on, and it's embarrassing. So I think going forward into the new organisation, we just need to take this really seriously, because people may listen, but you don't always see action on the back of it. And a lot of the guardians are getting quite frustrated by the lack of attention really in this area. So I would urge that all the directors, and the directors aren't the problem, right? It's right down into the kind of bowels of the organisation. It's the first line management tranche that's the real issue. And it's glad to, Ned's have had a session on this in PRC under Jane's leadership. We're glad to see that we're rolling out the kind of management development programme on a compulsory basis, but we've still got a hell of a lot of work to do in this area. I don't want to sound too negative.
What do our management appraisals, because in some ways culture is an output of how we how people are managed and how they're appraised. So what does the management appraisal system look like? What are the metrics that we're using? What's the...
We can't... So for a long time we've been trying to say, look, everyone's guaranteed an appraisal once a year. We've never got anywhere near 90%.
We don't appraise people once a year.
Well, we do appraise them, but it's patchy. So in some directorates it's very comprehensive, in others it's less so, and that's something I think we again need to focus on.
So as Tom, just to reinforce that, Tom said I met with colleagues a few weeks ago, and there's a very, very, very strong feeling about management capability in dealing with issues. That then spills off into lack of confidence about HR process, but at the heart is just the quality of that conversation to try to seek resolution or something. And I think we ought to really try and focus on that. In the culture thing, there's the kind of softer edges, developmental edges of it, but there's the fundamental processes that make people feel fair and safe. Our processes are really poor, I think. Or it feels like it being new into the organisation, and that discipline that you'd have in an organisation like a trust, which colleagues will describe here, appraisal rates and appraisal quality are things that you're really going after all the time, and I can't see that here. So we're going to have to build some things here that are evident elsewhere, but I think do sit behind some of these problems.
Penny, I think as a board we should, offer all of our employees the chance to have the one conversation with their boss every 12 months.
It's not a high bar, is it?
No, it's
You should be raising that now. That should be a standard.
But it's not happened. It's not happened, and it's been very frustrating, I have to say. Many of us have the session as Ned's have sessions with the Guardians, with Tom, and the frustration over this is enormous. And I think it's an issue that we can resolve quite simply and easily. Yeah. And in a trust, you would really focus on getting this right. And we've unfortunately missed the goal.
Okay, so in our feedback from PRC committee, we should have some data. We should be looking at this in terms of what's happening.
Yeah, definitely.
Sarah Jane?
So totally, the annual appraisal is important, but we need to be providing the feedback every time we have an interaction, don't we? Whether that's in a regular one-to-one or in the moment, because that's an absolute backstop. And I think it connects to some of the challenges that Tom is raising, because we're not, I'm sure some are, but we're not always very good at having the initial conversation that manages expectations about what might be possible with the raising of the concern, and therefore it becomes difficult to close it down because we haven't agreed at the outset what a good outcome would look like, and that can not always look like the thing that someone's asking for. That's just the same as in a trust, but I think there's quite a strong sense that people just avoid having some of those more challenging conversations, which I think is all linked to we're not really giving feedback in the moment, we're not having the regular conversation, and in some instances we're not even having the appraisal. So I think the training was, I don't know where I'm looking, but the training that was developed was focused on trying to address that, but it's pushing against a culture, I think, which is more valuing of expertise than it is of general management.
Okay. Anything else you'd like to see happen, Tom?
I think just keep pushing on the leadership behaviours and our expectations, and I think part of that is also induction when people join our organisation, not seeing that being sort of laid out clearly to people when they come into the organisation, and therefore it's very more difficult to then start setting the bar around what we think, how we see that working.
Okay. think we've got an opportunity with the integration.
Absolutely. I think just another thing to add, we discussed this, Tom, when we met, that the burden on guardians themselves is actually really quite significant, and when, that's fine in a stable organisation that's doing really well, we've got an exceptionally difficult set of circumstances, so we have to think about how we look after those individuals, because they are the sponge for an awful lot of grief and anxiety and anger, and they're not jobs you can do for very long without it having a kind of an impact on you. So I've got to think about that.
Jane?
Just a couple of points, and echoing a lot of what Andrew has said about our regular interactions with the Guardians. One thing that PRC has looked at consistently over the last year or so, and I'm sure before that, is span of control and how many managers you've got. And you do, I think it's quite common to a lot of healthcare systems, you kind of end up putting people in charge of other people because they're experts or senior, but actually, they don't need to necessarily be managers. And I think we have a very high proportion of line managers to staff in NHS England. I think there's a chance in the reorganisation to correct some of that, to get people in the right jobs. So that's one thing. And just to reinforce what I said earlier in the brief committee report, there is an attempt in some of the leadership and performance training, as it was designed before the announcement of the merger. Some of that is being pivoted to try to address the particular stresses and strains coming out of this process. So there is a recognition that, you can't just carry on business as usual, but trying to look at giving people the skills to manage people through a period of particular stress, supporting the guardians and others.
Is it?
Just very quickly, this isn't the only area within HR that we picked up from an audit committee point of view where the processes are non-existent. So the levers process was all. So I just wonder whether there's a bigger cultural reset to pick up, and whether there's a role for the internal audit as part of that in checking that we're actually delivering on it, because this isn't the only space where we're weak.
Absolutely, and we need to link that into the integration work. Okay, so thank you, Tom, and to colleagues for doing good work in difficult circumstances. Bethany, welcome.
Thank you. So I'll just give a few highlights as well. So first of all, to give an update following the publication of the 10-year plan and the DASH review. So we are meeting regularly with the Department of Health and Social Care at both a senior and working level to begin the planning and transition activity for National Guardian's Office functions. Some immediate issues that we've discussed include staffing, communications, high-level timelines, and any legal or contractual issues that are connected to the functions. And of course, focusing on ensuring that there is continuation of guardians within NHS trusts. Detailed planning is at a very early stage at the moment, but we do aim to have substantially delivered the National Guardian's Office shutdown by Q1 2026-27. So some other key highlights in the report. We now have more than 1,400 guardians trained and registered on our published directory from a variety of organisations, as you can see in the report, and we continue to collect quarterly data from guardians. The most reported theme through Guardians in 23-24 were cases that involved an element of inappropriate behaviours and attitudes, closely followed by cases that involved an element of worker safety or well-being. But out of all those workers that did speak up through Guardians, just short of 80% said that they would speak up again, which is really encouraging. The biggest gap that we've noticed in the staff survey, and that kind of links into some of what Tom's been saying, is actually that there's disparity between confidence in workers feeling safe to raise concerns and confidence that actions will be taken. So again, it's working with leaders and organisations to make sure that they're listening properly and they are taking the appropriate actions and follow up to close that loop and that cycle. In May, we published our Speak Up review into the experience of overseas trained workers that had a number of recommendations, and a steering group has been formed to see through those recommendations and keep them on track. We continue to work with stakeholders. A particular area has been with NHS England and CQC, looking how to further embed guardians into ICBs, more standardised, and also into primary care services as well. With regards to our guardian support, we continue to support our guardians, especially over the coming months through the transition period. So we continue with their annual refresher training, CPD, and look at their compliance against training, etc. as well. You can read in the report the engagements and communications that have gone on over the last year, and I think just moving on to next steps, although we are moving into the transition period, we have got a number of work streams that we will be continuing with because they're really important to be able to support the guardians, leaders and organisations. And we are hoping to do a short speak-up review into the experience of temporary workers, which should hopefully start in the summer.
Okay, thanks Bethany. Any questions? Okay, so one thing I would say, which also was talking about this with Duncan at the Chief Nurse Conference earlier in the week, so quite a few things in the report I did and the recommendations about bringing functions back in-house, as it were, of which this is one, recognising the work that NGO's done over the last 10 years to really create what is now a significant establishment of freedom to speak up guardians across the whole of the NHS and in NHS England. But as we were talking about, crucial thing is if we bring the functions back in-house more, as we're doing with this, we've then got to deliver against them. Mm-hmm. So it's a bit of, we have to say thank you very much for all of your work, but it's a big responsibility, which, to link into the previous agenda item, means we've really got to step up our own internal processes, whether it's in people management or it's in wider quality management.
I think being clear about the role of freedom to speak up within NHS England is important, because whilst there's an internal piece of work to do, we did embark on a bit of work last year around what happens in trusts and where do they go when there's an issue. We were doing some work with CQC and with the NGO, and I think we need to kind of revisit that and clarify it, because there is out in the field where we've had instances where people have raised issues, and it may concern, I don't know, a board member or someone senior in the organisation, where issues haven't been addressed. People feel that they've got nowhere else to go, and we just need to kind of be clear about those routes where people can speak up safely, and that's a bit of unfinished work that we need to kind of cap off.
Yeah, absolutely. And just to say that that has come up with some guardians recently since the announcement and the publications, to have that clarity on what the escalation routes would be moving forward. Yes.
Yeah, we did address some of that. But yeah, we'll pick all of that up. Okay.
Just my experience of when I was a regional director, and just thinking about with Tom actually, but we've got, as well as having guardians embedded in our directorate, we also had a lead, so we did actually manage quite a lot of conversations, particularly the more senior ones. Where there would be issues, and the key thing that Sarah Jane and Tom was describing was about active listening and actually getting to a place of, well, what does a good outcome look like? And I think we do mitigate quite a lot and manage that and really help people reach a resolution before it escalates further. It's not formalised, so I agree. In the reorganisation, I think we need to make sure that that's recognised. There's a lot happens in regions that are not formalised. So I think we need to make sure through the operating model we pick that up.
Yeah, we'll definitely pick that up. So thank you. Thanks for bringing that. Okay, we've got one item just for information, which is the feedback from the consultation around the Oversight framework. So that's just to be read. We don't need to discuss that, do we, Glenn? Or?
Just a moment on it.
Yes. Oh, okay. All right. Good.
So this report's back on the feedback from the consultation, including moving to a more focused set of indicators. So we've referenced the Oversight framework a few times today, but one thing I just wanted to emphasise, that as we move to a more focused set, we are still expecting boards, including this board, to look at a wider range of indicators. But I believe in the adage that if you prioritise everything, you prioritise nothing. So what we've done here is identified these measures, and each year we'll come back to look to see whether we change those based on priorities, but also based on the 10-year plan priorities, because it's clear that there are a lot of areas in the NHS, particularly those that we prioritise, that haven't got sufficiently robust indicators, so we're working on those. But this oversight framework will be dynamic. It's rules-based, and we will link freedoms and incentives to it, but also link it to the improvement offer that will be across the board, including into intervention for individual organisations. We've already shared provisional Q1 data with colleagues in the system. We will move to the formal publication of that in August, linked to public-facing league tables. And I think the response has been really positive, as Jim referenced earlier.
Okay, good. But I think we do want to keep revisiting, have we got the right data in there, which fits in with the earlier conversation. Okay, does anyone have any other business? Okay, just one from me, which is that we are going to be changing some of our NEDs and some of our board committees as we move into the autumn, so we will share more details on that when we get to that stage. But I would say a very big thank you to all of my NED colleagues for sticking with us as we've been through an awful lot of change over the last few months, and it's much appreciated that people have largely remained very committed to the role, well, not largely, 100% very committed to the role, and have provided some fantastic input, support and good challenge to our executive colleagues. So thank you to our non-execs, and very many thanks to our executive colleagues for all of the work here, and most importantly to all of the staff working out in the service. Our next meeting is in September. Can't remember the exact date, but look forward to seeing everybody then, and hopefully some people manage some of a break between now and then. So thank you, and thank you very much again to members of the public for joining us.